I would like to express my happiness and gratitude for being here, participating in this beautiful scientific meeting. At first, I must thank all people who are preparing this successful conference, and I'm very thankful to Dr. Salah Harboon for inviting me and hosting me in this beautiful conference and a beautiful resort. And I hope this will be the first and not the last time, and the meeting will come, inshallah, in the future. My name is Mahmoud Farouk Sharif. I'm assistant professor in pathology department, Faculty of Medicine at Assiut University, and I hope I can put some scientific material regarding the utilization of fine needle aspiration cytology in thyroid gland diseases. Even fine needle aspiration. Even fine needle aspiration cytology is very easy and simple procedure accepted and applied in many medical centers. There are many challenges that make application of fine needle aspiration somehow problematic in the medical field, and I will discuss these challenges in the following sections. At the beginning, we have to be aware about the best method for pathologic diagnosis is to examine the whole excised specimen, because with presence of whole excised specimen, we can evaluate and see things more clearly from different region to another. And we can see the nodule size, nodule outline, and even with small nodules and any lesions that might be missed even in previous radiological evaluation prior to surgery. And regarding the microscope, also excised specimen, we can examine the appearance of the tissue from different side to another. As you see here, the variation, the morphology from one location to another. And the external tumor tissue also can be examined clearly. And very importantly, this penetration of the tumor cells breaking into the capsule to the surrounding tissue with the hallmark of follicular carcinoma. And this finding never be seen except in excisional biopsy. Even fine needle aspiration cytology or torcut needle biopsy cannot give us any information about this penetration, and as I will discuss shortly. But it does not make sense to do excisional biopsy for all patients suffering from thyroid diseases. We have to do a non-invasive procedure. We have two players in this field, which are fine needle aspiration cytology and true cut needle biopsy. And I will mention shortly the difference between these two procedures, because I found some physicians find some difficulty to differentiate between what is called fine needle aspiration and core needle biopsy. In fine needle aspiration, we insert a very small needle into the thyroid nodule or thyroid cyst, aspirating just cellular element. We just getting cells. We do not get tissue pieces. This is a fine needle aspiration. But in true cut needle biopsy, we insert a larger bore needle to get a small piece of tissue. This is a biopsy, core needle biopsy. We are getting tissue biopsy, not cellular element. And to make the issue more clear for you, this image illustrates the difference between as you see here, this is a section from pomegranate, and you can find here the cells are arranged in groups and separated from this neighboring group by this white band. This is how can we evaluate the excisional biopsy of the pomegranate. All the information for the diagnosis are present in one image. But in cytology, we just are examining these scatter cells. Only these scatter cells are present, and what only can fine needle cytology provide. As you see here, this is a follicular adenoma, and very nicely well defined without any capsular penetration. And these follicular cells are different from those extra tumor normal thyroid tissue. This is the excisional biopsy of thyroid adenoma. But this is how fine needle aspiration looks under the microscope, just dispersed cells with some cellular articulation and the nuclear morphology. With a rigid scientific criteria, we can point to this as follicular neoplasm without any specification whether the lesion is benign or malignant, because we are not aware about the intactness or the penetration of the capsule. And even with the aid of core needle biopsy, when we use core needle biopsy, we insert a large bore needle into the neoplasm to get a small piece outside. As you look here, this is how core needle biopsy appear under the microscope. All the cellular elements are present in their true location, and this is part of the capsule can be seen here. So we can consider core needle biopsy as part of the image with a preservation of architecture, but in fine needle aspiration, all of these architectural information are missing. And this you can see here, this is true cut needle biopsy of pomegranate. You can see the arrangement, tight arrangement of the cells separated with this white band, very similar to what is seen in excisional biopsy. And keep in mind, and even with the aid of true cut needle biopsy, we cannot differentiate between follicular adenoma and the follicular carcinoma because this depends on the examination of the whole capsule all around the tumor. Sometimes we can find only focal penetration of the tumor cells at one area that is unfortunately maybe missing in true cut needle biopsy. How do we do fine aspiration? The needle is inserted to the nodule just with negative pressure and some cutting motion. We get a small material harvested here in the hub of the needle, and the material will be expressed on the slides, and we do smearing to get the slide looks like this. These are the smear and the cells dispersed all over the entire slide. This is a fine needle aspiration technique, and it's a very simple procedure. But keep in mind that many cases, as you know, the thyroid gland is a highly vascular organ, and when we do fine aspiration, sometimes we're just getting bloody material devoid of any cellular population with a diagnostic significance. So when these slides will refer to the cytopathologist, it will report or give the idea about these slides are unsatisfactory for diagnosis because all of diagnostic information are missing. And that's why what is called rapid on-site evaluation emerged as an important step in the procedure. And after smearing, we do a fast stain that may take about 5 minutes to make the slides ready for microscopic examination. And with the presence of experienced or trained cytopathologists, we can examine the slides under the microscope beside the patient and evaluate the presence of adequate cellular material and decide whether or not we need to do another aspirate if we are just getting bloody material. And not only the rapid on-site evaluation is useful to eliminate the possibility of non-diagnostic material, but also sometimes the rapid on-site evaluation directed the teamwork to the possibilities that may not be taken into consideration before the procedure. 1 month ago, we had a case of a 40-year-old female patient presented with left thyroid nodule and left cervical lymph node and referred to cytology lab to do a fine needle aspiration cytology. When we did fine needle aspiration cytology from the left thyroid nodule, it was revealed to be a non-neoplastic condition. This is a benign colloid nodule. But when we did the fine needle aspiration from the left cervical lymph node, it was revealed to be malignant adenocarcinoma with a morphology completely different from what we are usually experiencing from thyroid origin. The morphology of adenocarcinoma are very similar to what we are seeing usually from the breast origin. At the same site of aspiration, we asked the patient to uncover the left breast and left axilla. We found multiple axillary lymph nodes. And when we did fine needle aspiration from these lymph nodes, it was revealed to be adenocarcinoma, ductal adenocarcinoma of the breast metastatic to the ipsilateral axillary and cervical lymph node. This is the marked importance of to do rapid on-site evaluation beside the patient during the procedure. To whom we can do fine needle aspiration? Practically, fine needle aspiration is indicated for all patients presented with thyroid nodules with some limitation. As mentioned by Professor Dr. Salim, that when we do TSH level and it is revealed to be decreased, and with the aid of thyroid scan to be reveal the nodule was to be hot nodule, fine needle aspiration can be avoided in such situation because the very rare possibility that the lesion will be malignant. And also, if the thyroid is thyroid nodule is accidentally discovered and it was less than 1 centimeter with no suspicious or alarming radiologic criteria, also fine needle aspiration can be avoided in such cases. What can we expect from cytology report? The cytopathologist put the diagnosis into one of the 6 Bethesda system for cytology reporting system. As you see here, the Bethesda system, the Bethesda refers to Bethesda in Maryland at United States, where this system was established and sponsored by National Institutes of Health and widely accepted. This is American classification and widely universally accepted as the standard method for reporting cytopathology in thyroid. As you see here, insufficient for diagnosis is the first category, and this when we expect to find this report or find this category when the slides are devoid from any cellular material, cellular element of diagnostic significance. It does not mean that the lesion, the patient has no malignancy. It means that the cytopathologist has no message, true message received from the thyroid nodule, and it requires repetition of finding aspiration. Also, we have atypical cells of antidermal significance. This is one of these categories, and it signifies the presence of some alarming cells with very few number, insufficient to get the diagnosis of suspicious for malignancy or even malignant. And the utilization or application of rapid on-site evaluation markedly decrease or eliminates the possibility of insufficient for diagnosis and atypical cells of antidermal significance. But with the aid of rapid on-site evaluation, we can see many reports signed as insufficient for diagnosis or atypical cells of antidermal significance, which requires repetition. And there is a very important point when to do a repetition of finding aspiration. One of the famous questions I received is when to do a repetition of finding aspiration. When we do finding the aspiration, the needle motion inside the thyroid makes some changes in the nuclear criteria present in the thyroid tissue. And these alarming nuclear criteria, if harvested in a very early fine needle aspiration, it may be a source of false positive diagnosis. So many also consider if we need to do a repetition of fine aspiration, we have to wait for about 3 weeks to make these changes come back to the normal morphology and do fine aspiration to avoid false diagnosis. As you see here, the suspicious for follicular neoplasm and suspicious for hairy cell neoplasm, because we cannot differentiate between follicular carcinoma and follicular adenoma or hairy cell carcinoma versus hairy cell adenoma based on fine needle aspiration. As you see here, the philosophy of follicular neoplasm, this is a follicular adenoma, follicular carcinoma. The cellular population here is very similar to what is present here. And this is an image from cytology of follicular adenoma, and this is a follicular carcinoma. You can appreciate the marked similarity between these two slides, which makes the issue impossible to differentiate between follicular adenoma and follicular carcinoma, because it is based on the presence of this penetration, which cannot be appreciated unless you have excised biopsy. Many articles and studies were concerned with the accuracy of finding the aspiration. And this is one of the famous study published in 2020. This is a meta-analysis applied or studied many comparative study between many eligible studies. As you see here, these are 10 eligible studies comparing the accuracy of finding aspiration and core needle biopsy in thyroid. And you will see here the sensitivity in fine needle aspiration is higher, slightly higher than those of core needle biopsy. But in other studies, you will find the opposite is reported. And this heterogeneity in the results might be attributed to the technical issues with if the availability of rapid on-site evaluation, number of passes, and experience at hand. And as a whole, if we collecting all these findings, we will find the sensitivity of finding aspiration is slightly lower than core needle biopsy. And I believe in the sensitivity of finding aspiration in thyroid nodule is slightly lower. You will find many false negative diagnoses. As you see here, you will see more true false negative diagnoses in finding aspiration if compared to the core needle biopsy. And this might be due to the technical and insufficiency of the cellular population required for the diagnosis when we insert the needle. Sometimes the cells we are searching for are not present on the slide. Finally, they took home message. The finding aspiration is very easy procedure, very simple, but it unfortunately can be affected by many facts. The power of the aspiration, the operator, the presence or absence of on-site evaluation. All of these parameters can affect the accuracy of finding aspiration. It can be avoided in hot nodules, as mentioned by Professor Dr. Salim, and also if accidentally discovered 1 centimeter or less centimeter with benign radiological impression, we can avoid the use of finding aspiration. Rapid on-site evaluation is very important, as I mentioned. It provides a comparable accuracy with corneal biopsy with superior sensitivity biopsy over finding aspiration cytology, and it's still we do not have the chance to differentiate between follicular adenoma and the follicular carcinoma based on finding aspiration and trocar needle biopsy. And sometimes we can do frozen section for those patients to catch up the follicular carcinoma before a closure of the wound. If the patient, if the nodule revealed to be follicular carcinoma by frozen section, the surgeon can shift to completion thyroidectomy at the same session, and this is very useful if frozen section is available in the center. I hope I provided some useful information for you, and I wish you good luck. And Assalamu alaikum wa rahmatullah.